And that's not to say we're still admitting patients with inborn errors of metabolism that have this unless they're having really virtually no symptoms. But we've got a number, I should say, we've only had one hospitalized, but we've had 2 or 3 who have been able to take care of themselves in the community. Okay, next slide. Other comorbidities. So this question here is, and of course, we're not going to see, VLCAT or LCHAT or any of the disorders, propionic acidemia, any of the disorders that we typically see. But one reason I thought this was interesting was that cardiovascular disease and obesity tend to be things that are really driving the mortality as far as comorbid conditions. I was actually surprised. I think diabetes is the closest thing that we can get to for our classes of disease. And I know it's not a perfect match, but is actually relatively less of a comorbid risk factor by itself than some other things. Okay, next slide. So what I'm going to say here is, before I turn it over to Mark to talk about the things that are very specific to FAODs, is that the best way to prevent problems, and we don't know if this will mutate and change, we don't know if it'll get easier, it will get better, but we're definitely going to hit a second wave now, is to use the social distancing, public health measures, stay home when you can, avoid large gatherings, frequent hand washing, wear a mask, avoid places where people are not doing good public health management to the best that you can. I think it's safe to go to the doctor's office. I think you need to go to the grocery store, but to the extent that you can follow these as strictly as possible, this was going to be the best way to protect yourself over the next 6 to 12 months where we're still dealing with this. All right, Mark.
All right, thank you, Michele. So, as Michele said, there is no specific COVID fatty acid oxidation problem. There are general concerns that apply to everybody, and yes, like any infection, this could set off this could be a trigger for an acute metabolic crisis. Although in reality, it doesn't seem to be setting off a lot of people. Which is a good thing. So it's really, the focus should be on FAOD common sense. And so it's important to remember the basics, obviously, especially in unfamiliar situations, unfamiliar experiences. So avoid prolonged fasting, obviously, according to what your clinic has advised you. The body loves a routine. The body behaves in a very predictable way in general. It has, it absorbs calories and it utilizes that energy, and and if you don't eat and you don't go those calories, it then moves and utilizes stored body sugar. And once the major store of body sugar or glycogen is used up, then it starts to break down fatty acids or manufacture sugar from other sources. When you exercise, the body has a predictable way. When you start exercising, the muscles will use stored sugar as when you initiate exercise, and then if you continue exercising, it utilizes fat. So a regular routine is what the body likes. So regular meals, regular calories. Of course, fluids, especially if you're sick. The more of a routine that you can develop and take precautions around that routine, the better your body will behave. Obviously, avoid high-risk situations, as Michele has spoken about. Things like vaccinations for influenza, things that you can prevent. And hopefully once there's a vaccine, an effective vaccine, hopefully for COVID, then that will be, part of our armamentarium as well. Some specific things at the beginning of the pandemic, home care companies, certain pharmaceutical companies ran into problems with shortages. There were problems with delivery. There were problems with, meeting commitments. So where possible is make sure you have supplies on hand. If you are starting to run low, try to renew that supply or refresh that supply early. Don't wait till till you've run out, especially if the pandemic ramps up again and it is seemed to be surging, then there'll be increased demand on healthcare supplies. So you want to make sure that you are stocked up. Make sure you have an up-to-date emergency protocol. So have that ready, have copies ready so that they are readily available. And in some clinics, they provide home care protocols. So what to do if you or your child is sick at home. And some clinics do that, some clinics don't, because they want to make sure that patients call the clinic. But whatever protocols you have, make sure they're up to date. As Michele said, lots of people are calling because they don't know what to do. This is an unfamiliar situation. If you're finding yourself running into an unfamiliar situation with yourself or with your child, call the metabolic clinic staff early to talk it out. Don't wait till if it's really something that you're not comfortable with. Don't wait till the problem becomes more of an issue, and they'll help you think out of the box about what to do with it. And that is useful information for then making decisions about other situations that might happen in the future. And then should you find yourself going to the emergency room? Okay, so you are the patient or your child is the patient. You are coming, you are worried about their care. On top of everything, you have to worry about COVID now. And you're entering a situation where they are flustered in the ER, they're dealing with COVID, they're dealing with other patients, and you're coming at them with a rare disease. Well, ER doctors can be, flummoxed by that. So provide the emergency protocol. That provides the information, that should have the information on it that describes the disease, describes the symptoms to look for, describe the testing to order, describe first aid treatment, in terms of IV fluids, for example, with sugar, and who to call. If you don't have an emergency protocol, ask for one. If somehow you can't get one, then there is something called the New England Metabolic Consortium. The New England Metabolic Consortium is a consortium of metabolic clinics, and the people who work in metabolic disease in New England get together every year. There is a website that has acute illness protocols on the website that is available that you can access. And so if you don't have one, you can actually download it from that website and use that, or direct the doctor who's seeing you to download the protocol. If you're in the emergency room and you give the protocol and the doctor does not seem to be responding the way you think he or she should, not doing things quickly, not understanding, not listening, then what's very useful is if you have them call your metabolic doctor, so they can talk doctor to doctor. If they won't do that, then the next level would be you call your metabolic doctor. You should have that access information, and have that metabolic doctor call the ER doctor. Tell them who they need to talk to. When I do that, and what many metabolic doctors do, is because ER doctors are not familiar with metabolic disease, we start to maybe dramatize it a little bit, use words like sudden death, use words like rhabdomyolysis or muscle breakdown, things that the ER doctor can understand to help put some fire into the situation. And the other thing to do is, of course, before you get to the ER, call your metabolic doctor or call the team and say, you're on your way to the ER. And often they will call the ER, talk to the doctor, and give them a heads up, which should make your path a little bit smoother. So at this point, that's this part of the talk. Michele and I will take questions. So why don't we open up the microphones? Or
yeah, everyone can unmute if you'd like. I just want to interject that Dr. Korson mentioned the New England Consortium. On our medical information pages on the FOD Support .org website, we do have that link. So you can go to that and look at some of the emergency protocols. Another suggestion would be, and this is from an attorney that has worked with some of our families, for your emergency protocol, they suggest to have it on, if you can, your specialist or your primary's letterhead, have it signed and dated every year to keep it updated, because legally, I think, from what I've been told, some ERs don't have to follow it. if it's not signed, dated on a yearly basis. So that's, something to think about. So
Actually, and just to add to that point as well, even if you're downloading the protocol from the consortium website, take that and have somebody sign it, because you're right. If it's outdated, it's not that they don't have to, they're not sure whether it's relevant if it's very old, and they may not take chances.
So.
I think there was one in the chat thing here. It said, vitamin D is a concern with COVID. Are there ways for those with FODs to improve deficiency? So I can get started with that, and Mark, you can certainly jump in if you have other thoughts as well. So vitamin D deficiency is very common. It's particularly common for those of us who practice in New England, because it's during the winter here. I mean, they've done studies on this. You could go outside naked for like an hour a day in January, and the sun just never gets high enough that would actually make any difference for your vitamin D level. So your only way to get it here is either to fly to Florida, which would be great. I wish I could convince someone that was a good idea, or is to take supplementation. So if you have like a high intake of vitamin D food, so that's one thing. So you could look for that. The nutritionist in your clinic can help you with that. Otherwise, supplementation, I think, particularly in winter months, is really important. And then in summer months, I think if you can get outside, if you're not having sunscreen on every single second, so sometimes doing 15, 20 minutes without sunscreen and then applying it on can help you boost those levels. It's been shown to be important, not just for COVID, but for a whole host of different things. So I think it's an important thing to keep track of. We usually check it once to twice a year in most of our patients.
I think there's another question there in the chat. I did a clinical trial for vitamin D deficiency. They gave us 5,000 units, I guess, a week. It did not increase my level much at all. Vitamin D is a long game to keep your levels up. Not so much a question, just I guess, an observation.
Yeah, I mean, there's a couple of things for vitamin D when it doesn't come up. One, the once a week dose should have been 50,000, not 5,000. So I'm not sure if that's a typo, or if it was only 5,000. That would probably not do five. If I was going to do once a week, I'd do the 50,000 dosing. The other thing, okay, good, perfect. They're saying yes. So that should have brought it up. I mean, studies show every once in a while, it's because the brand is not good, but if you're doing the 50,000, you're probably doing it by prescription. So some people do seem to have a harder time, whether there's an absorption problem or different kind of, other metabolic differences in how people process it. I don't know, Mark, if you have a better idea. I think, if we had an endocrinologist here, they'd probably be able to tell us more detail, but we do occasionally see this. In which case, usually people who fail that, I just try to get them on the every day. We'll do a higher dose every day. And with a good brand, we usually can bring them up, not necessarily an optimal level, but an acceptable level.
Yes, and sometimes that we have seen where people's levels don't go up as expected. You start looking at the gut a little closer to find out why people aren't absorbing a dose. And some practitioners will actually just go up higher on the dose to see if they can get what they can get absorbed. And that's okay as long as you're monitoring levels.
Do people feel, how are people feeling about COVID with having, and a metabolic disorder, whether it's VLCAT or LCHAT or MCAT? Are people feeling comfortable at this point? They know how to protect themselves, or what, what to look for, or do people still feeling like anxious about the situation?
My son is now 34 and he lives out in LA, and he's surprisingly very cautious. He's not highly anxious to begin with, but he's cautious, and he's always known that washing hands is important for anything living. And touching other things and that. So having the MCAD for him, and in the midst of all of this, isn't too anxiety provoking. It's maddening sometimes because he's an extrovert, so it's not being able to get out and that. But for him, I think he's been okay with it. In listening to families in the Facebook group, sometimes not so. The kids the younger kids and some adults are extremely impacted, you know, with the increased anxiety with that.
I find that my anxiety tends to be on the higher side in general, but I feel like we've come to kind of have a normal. I find the toughest challenge for us is my oldest son has ADHD, and trying to manage being safe, but also allowing them to get their energy out and keeping them active and finding things to do. I find that that tends to be my biggest challenge.
And that's hard, right? So I think, you know, particularly for younger kids, some of the social isolation and not being able to move and not be able to play and stuff. But I think that's even true for us. I think we're just better as adults, right? I think the social isolation piece has been hard. I'm a hugger and a handshaker and a touch you kind of person. And it's like, I'm always having to think, okay, don't do that. Right. So, I mean, you know, it's hard. I mean, I think in you know, when people are anxious or upset, I'm one of those people who come and like, you know, hug, you know, some will hug people. And I'm like, I can't do that right now. So I think there's a lot of things that are challenging, but I think for young kids, that's been what I've heard from patients. It's that, you know, the virtual learning, the switching between things has been the hardest on them.
And what I've actually also heard is that, you know, what's particularly problematic is that there's a lack of trust in school systems who have, there are all kinds of pressures on them, some to open, some to stay closed. And so parents feel that ultimately they have to make the decision of what's safe because they don't necessarily trust the authorities. And that puts a huge burden on. As a result, some parents are less willing to put their kids in school, in which case what one can do to compensate is then find play pods where there, you know, is a designated 1 or 2 people who also come from cautious families, and you form a play, you know, a play group with them, and that's where they get their socialization, and it's not through a formal school setting.
I am personally pretty anxious. My family is all from an area that is very rural, and it is the belief of most of them that COVID doesn't exist. And early in the pandemic, I went up there to kind of convalesce and just kind of get away from everything. It was like now it's towards the beginning, but it was like in June or May. And now they're having huge surges because everyone's refusing to wear masks. No one believes it's happening. And I'm afraid to even go see my family because it's just not safe.
I think this is really hard. I think there's a lot of families that have that where not every, you know, they may not live someplace that is as well under control as where they already live, or they may have family members who don't see the same need for the public health measures. And you know, unfortunately, things like that are very emotionally draining without a real clear-cut good solution, right? There's just not a perfect solution to that, except that, I mean, one thing to say about COVID is that I know we keep talking about the new normal, which I hate, and I've been calling it the temporary normal, right? Because this too shall end. We are not going to be wearing masks for the next 10 years, you know. At some point, we're going to get an effective vaccine and effective treatments, and between, you know, all the different ways, we're going to go back to many things will go back to pre-COVID. So it's a temporary thing that we just have to get through and try to be safe while we're working on broader solutions.
But if you start from a safe foundation, and then normalize as much as possible in specific areas, like play pods, like, you know, in very specific areas, to normalize your life as much as possible, knowing you won't achieve normalcy yet.
Good discussion. We do have 2 other questions that I think we can hold off on answering if you two want to move into your next topic. It's 12:40 and we've got another 20 minutes or so.
All right. So why don't we
Okay.
go to the next topic, and then we'll entertain questions from that and from and any leftover questions. So this next section is on transitioning of a child to independence in terms of healthcare management. And I'm going to introduce this one by talking about some transition lessons from other disorders. So the story of childhood diabetes. So as many of you are familiar with, diabetes mellitus is a very dangerous disease, and it can be a very dangerous disease in childhood. What is involved medically is you have a child who has uncontrolled blood sugar levels. Those sugar levels need to be monitored. Insulin therapy is begun. It is the parent who administers the insulin to a young child, monitors the blood sugars, and brings that child into clinic. Of course, because diabetes can be life-threatening, parents are the ones to manage it carefully and completely throughout childhood. But what happened is, way back when in diabetes management, when those kids who were really well controlled through childhood began adolescence, they ended up in the ICU time and time again with in diabetic coma, with all kinds of complications. And when you wonder what happened, I mean, you were under perfect control. The adolescent would say, well, it's not my disease, it's my parents' disease. All right. Story of PKU. PKU is a metabolic disorder where affected individuals can't break down certain amino acids or building blocks of protein. So they can only eat a certain amount of protein. They have to take a special formula to keep their levels of phenylalanine down. If they don't do that, they can develop significant intellectual disabilities. They can develop seizures, psychiatric problems, and that could be lifelong. So once you alter diet like that, where you have to think, and this is familiar to many of you, once you alter diet like that so regularly, it's extremely intrusive, it's very complex. It often doesn't only change the diet patterns of the child or the patient, but the whole family has to operate around that. And of course, it is so complex, no child can do that himself or herself. So what the parents do is they manage it, and the child's levels are great through childhood, and in adolescence, they sort of go up and they go weird. And because the child is more on his own, and she's not controlling herself when she's around her friends. And again, it's because the locus of control for managing that child's disorder rests with the parents. It doesn't rest from within the patient. The locus control is external. And so what we've learned from those diseases is that it's necessary for the child to internalize the locus of control of his or her disease. And if it's inside, a child is less likely to push it away or to deny it. What does this mean for fatty acid oxidation defect? I'm not going to talk about specifics, but just, what does a child have to learn? Well, the importance of eating regularly and not fasting for too long, the avoidance of certain foods for certain patients, the necessity of taking medications or supplements as needed, and then how to manage yourself if you think you're coming down with something like a virus. So with that, I'm going to transfer to Michele.
So likewise here, I'm going to be doing something a little bit more general, and Dr. Korson will then kind of come back and do a few more kind of more FAOD specific ones. But, and so I'm doing this with a little bit of two hats. So one is the hat of a doctor who's helped a lot of families go through this, but also the hat of a mom who's now helping a 16-year-old transition and taking care of their own healthcare, who has complex medical needs. And it's actually interesting, as I prepared for this talk, I realized there were some things on the checklist I hadn't done. So we're driving home from school yesterday, and I'm like, do you know how to take care of your insurance or referral things? He's like, there are referrals? And I'm like, okay, yeah, there's definitely some things I need to do. So, but one thing I would say, for a lot of things, I think he is very independent. And, part of this is about what I feel like is another lifetime ago. I actually worked part-time as a Montessori teacher. And so I love this quote of never help a child with something he can do for himself. Help that child succeed, right? So what I'm going to say is transition and independence. And I think I loved Dr. Korson's stories to start this, starts early. as early as you can get the child involved in taking care of their disease, you should do it. Give age in developmentally appropriate explanation, work early on partnerships, whether this is, how do you want to take your MCT oil? Do you want to mix it in applesauce? Do you want to mix it in a drink? Kind of getting them involved in that process. This is how much we're giving, things like that. But also, having a chronic illness is not going to go away. And I think some of the stories that were shared earlier before we started is they can change over time. So teaching resiliency, how do you, if you get fatigued easier than somebody else, how do you compensate for that when you're an adult and maybe you want to do stuff? How do you pace yourself? Foster self-confidence. The more that a child or a young adult, or even as we're transitioning, these things will help us when we're trying to modify around illness. Next slide. How to start the transition. And this is again where I start. The earlier you can start. So slow, steady, increased responsibility. Reading labels. Okay, if your child's on some sort of fat restriction, at some point they're going to be going over to birthday parties and sleepovers and stuff, and you are not going to physically be there. For my son, he had, among other things, had celiac disease. So how does he avoid it? And he had a very, very severe form of it. How does he make sure he doesn't eat wheat? How does he make sure that, if you have to mix something when you're over on a sleepover, can they mix their own MCT oil or take it if they're taking it multiple times a day? Do tasks together. So when you're doing it, don't necessarily do it for the child. Try to do as much together, meal planning together, doing the medications. There's formula. Some we don't have a lot of FAOD patients who are still on formula, but some of them occasionally may have to for various reasons. Can they mix that? Listen to your child's concerns and fears. Ask about that. How are you feeling with this? Get feedback on this, because kids want to make their parents proud, right? And they may not always say it. And you may be better at doing it. It's maybe a little easier on an 8-year-old, which I would say, you should start young. A 16, 17-year-old may be trying to be tougher and show how much they've grown up. So I think still encouraging that. Celebrate independence, self-sufficiency. When someone does something, make a little bit of a big deal. You don't want to, go overboard, particularly with a teenager, because they're going to roll their eyes at you, which I have found things that they're really excited about at 8, they're not excited about at 16. But I still think it's important to be a little bit of a cheerleader, and I'm good with someone rolling their eyes at me. Remember, there's more than one. This is one that when you all figure out how to do this, let me know. Remember, there's more than one right way to do stuff. As people are transitioning, if you can let them do it, if it's not a safety issue, let them do it their way. And then also remember, it's not just about the healthcare related aspects of life to be independent. So, being independent and transition happening from being independent, transitioning from things. You shouldn't be the one prompting them when they're older to get their stuff together before they have to get off to meet the school bus or get to their carpool or something to get to their classes, right? They should be their response. You shouldn't have to be asking if they're still doing their homework. The more you can give them control over things like their homework, getting themselves ready in the morning, the more that will kind of, relate also to their ability to take care of their own health care. Next slide. And this is one that I added in. I don't have any data to support this one like I do with some of the other things. This is just my own kind of musing as a parent. It's a little bit to do a gut check, right? Examining I noticed that sometimes my fears of my child doing it on their own was probably worse than the actual reality, and teasing out which are your fears and which are legitimate concerns. Clearly, if your kid is not going to take their MCT oil and eat, hamburgers once a day and fast for 15 hours, that's not your not letting go. That's a legitimate concern. But sometimes I think that fear, are they going to be able to mix this? Are they going to be able to do it? Are they going to make the right choices? Are more about the fact you've been doing it for so long, right? And it's hard to let go. So, I always say, go easy on yourself. It's a process for you to let go as much as for them to take responsibility. And then this is my other kind of thing is, this is some of it is my doctor hat and some is my parent hat. Let the child talk in the clinic. Some parents are really great about doing this as the kids get older, and some parents have a harder time. And I will tell you, I have known to interrupt when I shouldn't. But the more you can kind of do that, the better, the more you're going to help them develop that relationship, leave the room, let them talk. If, sometimes it can be helpful. And that's often what I have to do because I'm very bad at interrupting. Next slide.
Oops.
Okay. The rest of this is something I actually found on the NEMR's site that I actually thought was really good, and it actually prompted me to kind of sit down and think about some things that I should be doing. So I'm hoping it's a kind of a framework, and I like the fact the guidelines are around this age, because again, for some kids this may be sooner or later, but this is kind of, I think, a nice thought process of how do you start the process of a transitioning. Explain medical condition and to patients. And again, I think you should be talking about this when they're younger, because they're going to realize that they're going to doctors a lot more than their peers. But getting feedback. What did you understand of what I said? Encouraging kids, I think, to spend time alone. We talked about this with medical professionals, just so they get used to having to answer those questions, feeling comfortable, developing trust in their providers. I mean, geneticists, we're not pediatricians, we're keeping our patients forever. So, the person you saw as a baby, maybe this is the same person you're seeing at 30. So, and it may not be, because you may move, but getting them used to that relationship. It also gives them a chance maybe to ask questions that, they don't care as much if we're proud of them as they do as you. So they may ask us questions they may not ask you. Teaching them to contact for medical equipment or supplies. So if they have a supply place that they have to get things, how do they order that? How do they do that? And again, I wouldn't have any 12-year-old doing that alone, but they could watch you doing it at this age. And I think learning to take medications, telling them why, right? Why are you taking, why do I have to take MCT-oil? Because, if they have to take MCT-oil, let's say before they play sports when they're in high school, you may be able to get them easily to do it now, but in high school, it may be a little bit more complicated if they don't understand. So helping them with that early. Next slide. 14 again. So you start, this is kind of things, is teaching them their own medical history. What things have happened? What does that mean? I'm not sure I agree with this one. The family history, I think, is a little bit more, I'm not sure if 14-year-olds would be super interested. Some may, some not, but I think at least getting it on paper, showing them where it has it, talking about why family history is important. I do think how to contact doctors is important. Like if you're sick, how do you get a hold of somebody? Because they're going to be, starting this age, less with you. This is the one I realized that I had not even thought about teaching my kids. So I thought this was really important, is how to refill a prescription, right? I call and I go pick it up, and I know, I don't even think about it. So teaching that, but I realized in a couple of years, I'm not going to be the one doing that anymore. So those are there. And then knowing current doses, medications. And I think even for our FAOD patients, why, like we may change it with age and with growth, or, with what their activity level is. I might give not as much of a dose before sports as I do before a meal. How do they know that they're carnitine and how we change it? Some of those things I think are important conversations. Next slide. And then around 17. So 17 is getting close to the end of the line here. So you need to start thinking about getting an adult primary care doctor. And this is variable. Some pediatricians keep kids to 21, some don't, but at some point they are going to have to do that. So looking for a good doctor. Adult doctors may not be as comfortable with inborn errors of metabolism. So maybe getting some recommendations in the community for people who might be more comfortable. Knowing how to get a copy of their medical records. If they're going to go, we spend a lot of time with college transitionings with patients. At this age, I spend like if you're sick, who are you going to call? Are you going to call me? Or are you going to go to, what emergency room are you going to go to? What's your local lab you could go to? This is something I realized I'd spent no time with, but explaining health insurance information, how to contact a representative. What if you're somewhere and you can't get something and someone's calling you, how to do that? How to get a referral to a specialist, right? If something happens and particularly if you're not home, college, new job, how do you do that? Starting to talk about transitions of healthcare. I mean, it's really unclear to me what's going to happen with the Obamacare, quote unquote. So I can't think of the real name of it. But, if they're not going to be covered, how are they going to be covered? What things their current coverage has, if parents' things change, how that happens, how it covers things if they're far away at college or in an internship or something. All those things are necessary. And then if necessary, if for any reason, like there's something where they may need disability, again, transitions happen when they get older. Next slide. I'm going to go through these much more quickly because I think it's not as is an issue for this population, but just in case someone had dual a child with more than one need. But again, I just think these are good kind of general things. Thinking about just long-term planning, For the most part, I don't think any of these kids in this community will probably need guardianship. But if there are any things that you think that a lawyer needs to be consulted, but at the very least, having them fill out paperwork to allow you still to talk to their doctors if they want that happening. And I do think wills and trusts are always a good thing to be thinking about, even as kids are older and changing, and go from there. Okay, next slide. This is the second part I think is more helpful. I do think it's really important to talking to your child-specific diagnostic group as they become independent in adulthood, because knowing again what kind of adult doctors they would be able to do, what kind of care they're going to be there. Some of our FAOD patients do have some significant muscle problems. Talking to other adults of how to, getting accommodations in college is different than getting accommodations in high school. Getting accommodation in the workplace is different than getting accommodations in school. So those kind of things I think are important. And, I also think it's a good time to talk to social work in general if you have any needs for which these transitions may be helpful. Okay. And so with that, I think that's my last slide. I think I'm going to hand it back over to Dr. Korson.
All right, thank you. And this is like really useful information, very good questions to ask. Just know that these presentations are recorded and will be on the Rare New England website and to use it as a resource. So I just want to close out by talking about some things that repeat what Dr. Spencer-Manzon has been saying, but also to focus a little bit more on the fatty acid oxidation defects, the concept of medical insight. So with a very young kid who might be getting sick, they're not going to tell you they're getting sick. You have to read it on their face, because all they want to do is play. And they're going to play and play and play. And you're going to start noticing maybe some subtle features. They may have been brewing something for a day or two, and you have to wait till you see it on his face or in his eyes or in his eating habits or in his energy level, and then something's going on. But by that time, an infection has already been brewing. So kids are not very helpful in their own care. When do kids develop medical self-awareness? When will they start participating and come to you and say, I don't feel well. I know this might be a problem with my disorder. So it's for developmentally typical kids, it could be 7, 8, 9 years of age is when they're going to start fessing up before you might read it on their face. But the other thing is full participation in managing themselves may be a challenge until they become medically self-aware. What does that mean? It means that it's all well and good to tell them what might happen to them, what they might feel like, but it's really abstract. And this is especially true for kids who are identified or patients who are identified by newborn screening and so are treated from the get-go, may never have had any significant clinical symptoms, versus a child who was diagnosed because they presented in a crisis. And so imagine if hypoglycemia, low blood sugar, is something to be concerned about, how to try to tell a child what that might feel like. It's all abstract to them. It's not as if they're going to start feeling like that and think automatically, oh, my blood sugar might be dropping. It's going to be hard enough for you to recognize it. It's going to be especially hard for them. And so a little bit of full participation is challenged that way. The other thing I would say is the concept of listening to your body. So again, infections are really important, can really trigger a problem for a child with an FAOD, or if for a patient who has a long chain, like an LCHAD or a VLCAD type disorder, then if they exercise too much, their muscles are going to ache. The muscles are telling them something. And for the most part, young kids just want to play. They just want to get through it. And they especially don't want to tell you anything if it means they're going to go see the doctor or go to the ER. They're going to push through it, and they're going to do it again and again and again, because they know the outcome is not going to be a good one if they say. So they have to learn to listen to their bodies, but that does not occur during childhood. It may or may not happen in adolescence. It often has to wait till they're young adults. But there are ways around that, and I'll get to that in a second. Knowing your limits versus pushing your limits. So pushing limits is undesirable. We all do it. Especially as adolescents, as young adults, we're in college. How many nights can we stay up without going to sleep? How much can we drink before we pass out or before we get nauseous? How much can we exercise? And it's the same thing for FAOD kids. Maybe not with family, but hey, they're human too. But they're going to want to know how much can I exercise and be okay? Because exercise is important. Exercise is not good. They will need to know how often. I mean, everyone tells me I have to eat 3 meals a day, but they will push themselves, and pushing to the point of illness is undesirable. But learning what your limits are is desirable. But that may require some trial and error, especially in adolescence. And that is not, one shouldn't be afraid of it, but they have to know the rules. And the rules are, if you are going to listen to your body, and this is what you have to listen for, then yes, you can play around. If you are going to exercise, then as soon as you feel something, or you have to listen to your body, and don't let them do that alone. Do that with them. So they will be happy that you are encouraging them to see what they can do, but you need to stay engaged with them. So so that you're on the same team, that you're helping them interpret what they're feeling, and you're able to give them guidance. But the two of you, you and your child, will hopefully figure out a safe plan that is a good lifelong lesson for how they're supposed to do this throughout their lives. So just some thoughts.
If no one has any questions for this section, we can go back to that question someone asked, Rebecca asked about immunizations, possibility of a COVID vaccination. The information coming out is very confusing. Do you have any recommendations for us to help us make this decision?
Yeah, I think I'll take a stab at this and let Mark also answer. But unfortunately, I think a lot of the stuff around COVID has been politicized when it didn't necessarily need to, and I think it's made for very confusing information. The reality of this is the vaccine trials have been stopped multiple times, which is pretty normal during clinical trials. Clinical trials are stopped for various reasons. There is a vetting process. We are not going to have it before the election, which I think was there was a lot of hand waving about that and whether that would be safe. There are a lot of checks and balances in this system, and I don't think they're going to put something out that's unsafe if for no other reasons. No company wants to be associated with an unsafe vaccine for public relations issues, as well as liability issues beyond just the other ethical issues of why you would never do that. So I think once it's been completely vetted and shown out, I don't think they're going to release something that is knowingly unsafe. That's what I would say.
Yes, and I would say you have to remember, choose your sources of information carefully. Those sources that are elected may not paint, that need to be elected directly, may paint a skewed picture. So try to look for, even though the Centers for Disease Control, the CDC, the Food and Drug Administration, the FDA, even though the leaders are appointed by the federal administration, they tend to be more reliable. And if you have two different organizations like that are saying the same thing, that's probably better. But be skeptical and ask questions.
I agree.
Good. The last question, Christy, who has 2 with LCHAD, her youngest did have COVID earlier in the year, and she wanted to know if those that have had anyone with an FOD, if they've had COVID, let's see, he's been okay so far. Are there any differences after they've had COVID? Have you seen anyone have lingering effects after having it?
I have not. So the patients who have had it in my clinic population, again, I mean, I've had a handful of patients that have had it, have not had a prolonged symptoms. But that being said, prolonged symptoms are actually out there. Now, if the child already had it months ago, like the prolonged symptoms usually happen close to the course of the disease. Like to the best of our knowledge right now, if you've not had symptoms, you had it like 4 months ago and you haven't had any prolonged symptoms, we don't think you should get prolonged symptoms. People who are going to get those are usually know about it because it just feels like a continuation of the disease that never quite goes away.
Okay.
Right, but you know, all the people who have had COVID are really pioneers when it comes to learning about this disease. So stay tuned. This should perhaps be a question that comes up in subsequent chat groups and conferences. Just
I personally had COVID myself back in April.
Did you experience any residual effects?
Yes, I still have some residual effects. My actually started, mine was mostly GI related because I have celiac, Hashimoto's, and hypoparathyroid. So the point of entry was mostly my gut. So I didn't have any involvement of my lungs or anything, but the inflammation, my CRP, for example, is still elevated. And every joint in my body still hurts. That has something that has not gone away. And also I'm still having issues with my stomach, even though my celiac was pretty much controlled before I ever had COVID.
Mm-hmm.
But I'm a nurse by trade, so I was in the front lines. I volunteer. Actually, I left my job. I took a sabbatical from my job. I work for Record Daddy and rare diseases. And I took a sabbatical when my state actually put out a call for nurses. So I volunteered to go and help my fellow nurses, and I ended up getting COVID.
Sorry.
Yeah, that's most challenging. My goodness.
Yes. So.
And we appreciate you being here. You
I
know,
hope nobody gets it. I don't wish it on anybody, of course.
Yeah.
But there is some. At least I'm still dealing with issues, and I even had some days I even have memory issues.
Mm-hmm.
Tough
Okay.
disease.
Yes.
It really is.
Thank you for sharing, Helga. Okay. Do we have any other questions that we can finish up with, so then you can get back to the auditorium and you can listen to the other talks? Anyone else? Quick question? No? Okay, well, I want to thank both Dr. Korson and Dr. Spencer-Manzon. Appreciate you taking the time today and this continued format